Hi, Justin. How are you?
Good. How you doing, Diane?
Good. I have a gentleman I would like you to see. His name is Mr. Patch. He's an 80-year-old gentleman with COPD, long history of smoking, has been in and out of the hospital numerous times in the past 3 to 4 months. This time he came in with shortness of breath, diagnosed with pneumonia. We have him on antibiotics. He's doing a little better. But recently we did a CT scan of his chest and it showed a right hilar mass. He knows there's a very good likelihood this could be cancerous, and he does not want anything done. So he does not want a workup and no treatment. So he was residing at a nursing facility, and I think the goals are for him to go back there.
Okay. Okay. Do you have any family support who's with him?
He has his wife of many years. They do not have any children. She is aware that he has a possibility of having cancer, and she supports his decision not to have any type of workup or treatment.
Okay. So the plan is he's going to go back to the nursing facility after we talk to him and finalize everything.
Yes.
No more treatment for the suspected cancer.
That's right.
Okay. And you think he has a pretty good understanding of that, and
I do.
that sounds reasonable. Okay. Well, I'll go ahead and see him. I may even bring up a POLST form with me, and we'll complete that. We'll see if that's something that he would like to do.
Okay.
And we'll go from there.
All right. That would be great.
Okay. I'll let you know
Thanks
after I see him. All right. Great. Thanks.
Okay.
Bye.
Come in.
Good morning,
Hi.
Mr. Patch.
Hey.
How are you, sir? My name's Justin.
Oh,
One of
nice to meet you.
Nice to meet you too. I'm one of the nurse practitioners here.
Uh-huh.
Is it okay if we talk for a couple minutes?
Yes, I know.
Okay, great, thank you. So I just want to explain, I'm one of the nurse practitioners here in the hospital,
Uh-huh.
and I work with a team that's called palliative medicine.
What's that?
Well, most people don't know what that means, but we do different things. We talk about pain and symptom management, and we try to make you feel as good as we can. And also just kind of offer you some support on thinking about next steps, where to go, what's going to happen. So I'd like to get to know you a little bit more and kind of think about how we can help you moving forward. So would that be okay if we talk a little bit?
Oh, yeah.
Okay. So I know you're here by yourself today, and I want to talk about some of the things that have been going on in your past and here in the hospital. Do you have a wife or family members that should be here?
My wife.
Okay.
She doesn't have to be here. We talked.
Okay.
Yeah.
So you're okay with that? You and I can talk, or I can
Oh.
even give her a call and telephone when we're done if you'd like.
She'll trust me.
Okay.
We can talk.
Okay, good enough. So I'd first like to say that, I talked to the clinicians here in the hospital.
Yeah.
They told me a lot about what's been going on with you. I looked at your chart. So I think I have a pretty good understanding medically what's happened with you over time and both here now in the hospital. But I'm most interested in your perspective as to, and kind of in your own words, if you can tell me just kind of what you're hearing from the doctors and what your thoughts are about that and just kind of how you're doing with everything.
Well, I got the COPD, had it a long time. It's bad.
Yeah.
And I come in here for pneumonia.
Mm-hmm.
They say I fixed it, but I don't feel different.
Yeah.
And he took some pictures.
Mm-hmm.
He said there's a mass in my lung.
Okay.
Probably cancer.
Is that what they think?
Yeah, that's what I think. They probably
Yeah.
think that too, yeah.
They did. They're worried about that, but
I said no. They wanted to do a biopsy.
Mhm. Okay.
Don't worry about it.
Yeah.
I mean, hey, I'm 80 years old, and they're not going to make me young, and I just want to be comfortable.
Mhm. Okay.
Yeah.
Okay. And that's exactly what I understand. I know that you've been in and out of the nursing facilities in the past. It sounds like you're really kind of wiped out and run down.
Yeah.
The COPD and the breathing problems really kind of is an underlying issue.
Yeah.
Now this issue about that mass or maybe a cancer.
Yeah.
Sounds like you thought a lot about that and what you want to do.
Worried about the wife, that's it.
Okay.
Yeah.
And you've talked with her a bit about this, and you're all on board with each other about that decision. Sounds like.
Yeah.
Okay. Any other concerns about what's going on now with your health?
Just don't want to keep coming in and out of the hospital.
Right. Okay. So I think we need to try to find a way to make kind of all this fit in. How are you doing with that, though? I mean, this is a lot to be taking in at one time. How are you kind of keeping up with all that?
Had a good life.
Yeah.
Good life. I don't know, I'm okay.
Okay. So our job is to kind of help through this journey for you. Think about next steps, think about some of the options, because we want to help you as much as we can, make you feel as good as you can for as long as that may be. Okay. So we'll figure out how we want to do that. So sometimes when people are dealing with everything that you're just telling me about now, they have questions about the future and what may happen. And it sounds like you've come to terms with what they think the diagnosis is. And sometimes people have more particular questions about time frames and even how long they may live. Is that anything you've ever thought about?
Yeah. Doc, I'm not afraid to die. But I don't want a long, miserable sickness. I don't like dying, but death is okay.
Yeah.
Yeah.
It sounds like you're quite at peace with this, as best you can be. Just thinking practically over the next couple of days, weeks, months, what are your hopes or expectations? What would you like to do?
No pain.
Okay. We can help with that.
Don't want my wife to suffer.
Okay.
And be easy. That's all I want.
Okay. Well, you certainly have thought a lot about this, and I think it's our job to help you through this.
Yeah.
Did they talk about where you're going to go when you leave the hospital?
Yeah. Going to a nursing home or something.
Okay.
I don't think you guys call them that no more, like long term. I don't know.
Long-term care facilities.
Yeah.
Okay.
It's the same thing.
Okay.
Yeah.
Okay. So when you go there,
Yeah.
I'd like to think about how we can discuss the goals that we've set forward today and think about making sure that they're followed tomorrow. So I want to talk about that a little bit. And I talk to all my patients about this, particularly people that are going through advanced illness and COPD, sometimes even cancer, because you've shared a lot with me so far this morning about what's going on. I want to make sure that those things are honored going forward. Have you ever done an advanced directive or a living will? Do you know what that is?
No, I haven't done it.
Okay.
We had some papers gave us before I came into the hospital. We didn't fill them in.
Okay. Do you know what an advanced directive is?
Not like when you tell people what you don't want them to do to you.
Right. So it's a medical directive that people usually do
Yeah.
that talks about things that they would want or wouldn't want
Oh,
if they were faced with a very serious illness.
okay.
So when you tell me things like, I've lived a good life,
Yeah.
and I just want to be comfortable,
Yeah.
in my mind, that sets forward a path that we should follow.
Okay.
Okay. And there's different ways that we care for people in the hospital.
Yeah.
Sometimes it's very aggressive, and we do things that are aimed to prolong somebody's life. Oftentimes that's even things like the intensive care unit and more aggressive type measures. So you've heard people talk about things like resuscitation and life support, breathing tubes, CPR and resuscitation. Those are all things that people talk about in an advanced directive. And people have often thought very hardly about this, about what they want, what they don't want. And that's one of the things I want to talk to you about, because it sounds like what you're telling me is those types of things, should your COPD or your lung cancer, if this is a cancer, should that get worse, that it sounds like you've got some opinions about what you want, what you don't want. And I think if your goal is comfort, we probably should talk about how to avoid some of those treatments and things that would probably lead you down a path that I think I'm hearing from you that you probably don't want.
Oh, yeah. Yeah. The wife's mother, she had tubes and everything. And I remember wife and I said, not us, huh?
Mm-hmm.
Not like that. So yeah, I want to
So
talk.
you've talked about it. You haven't
Yeah.
completed the form, but it sounds like you have ideas in your mind, and
Yeah.
you've talked with your wife about that.
Yeah.
Okay. All right. Tell me what you know about CPR. When you see it on TV or when you've heard about CPR, what do you know about that?
That's when they hit you in the chest or something? Or they,
That's one of the parts,
yeah.
possibly. Sure.
And they start your heart when it stopped or something like that?
CPR is a measure that when people either their heart stops
Yeah.
or they stop breathing,
Yeah.
Those are measures that they take in an aggressive way to sustain your life and to regain your breathing and to regain your heart, okay? Now, for somebody out in the community who has a sudden heart attack that is otherwise younger and relatively healthy, sometimes CPR can be very helpful to resuscitate and bring people back to a normal quality of life. But when patients are in the hospital and dealing with a lot of things that you're dealing with in terms of the COPD and the breathing problems and potentially a cancer, CPR doesn't often work as well as we would want it to get people back to a condition that they would find satisfactory. So that's why we have these conversations about CPR and what's reasonable. But there are other ways we can treat you to make sure that you're comfortable, and that might be through medications or other things. So I kind of wanted to gauge what your understanding of CPR is.
I think I understood what you said. If they did it on me, I just get to die twice. I mean, it's like, I know, they're not going to make me healthy.
Correct. They're not going to cure your underlying problems.
Yeah.
And these are hard decisions that people make through life, but I'm getting certainly the sense from you and all your honesty about what you want. There's a form that I'd like to go over with you that will help sort of honor a lot of those preferences and things that you're telling me now.
We can do that now?
Yeah, we can.
Oh,
We can do
okay.
that. Yeah.
Yeah.
Okay. So this form here, this is not an advanced directive that I asked you about before. This form here is called the POLST form, and that stands for the Pennsylvania Orders for Life-Sustaining Treatment. Okay. You see, it's a nice bright.
It's quite a color.
It is quite a color. It's quite a bright color, but it's that way for a reason because it's an important form, and we want people to recognize this and know what that is.
Okay.
Okay. So what I'd like to do is I'm going to walk through this with you, and I'll just get a little closer here.
Okay. Yeah.
Okay. So this form is broken down into sections, and this talks about different scenarios that could potentially happen to you either now in the hospital or if you would go to the nursing facility. And this is a way for us to communicate this conversation that you and I are having now onto the next level. Okay. So given everything that you've just told me, it fits very nicely into this form because I want to make sure that we're doing everything for you that you want.
Okay.
But we also don't want to do things for you that you may not want and you might find to be too burdensome in the whole scheme of things in terms of your quality and your comfort. We want to honor all that.
Okay.
So I'll walk through this with you and we can complete this.
Okay.
So again, this is called the Pennsylvania Orders for Life-Sustaining Treatment form,
I can see it.
or the POLST. You can see that, okay? All right. So there are 3 sections, okay? Now, Section A talks about cardiopulmonary resuscitation, or CPR. That's what we just talked about a moment ago. And this says if in the scenario where somebody would actually find you and you had died, you can't find a pulse, you've stopped breathing, there's 2 options. So one option would be to just allow that death to happen naturally and not do any aggressive resuscitation measures and allow you to die peacefully. The other option would be to try to reverse that situation, administer CPR, which would include chest compressions, which you see often on TV where they compress someone's chest, but also likely breathing tubes or ventilators, and oftentimes even electric shock, or you've seen them with the shock paddles to the chest. Those are resuscitation measures if we would find that you had died. Okay. So I'm curious as your thought about, but I think given what you've told me, I think I know what your answer may be on that.
If that happens, just let me go.
Okay. So we're going to.
I don't want them paddles.
Right, and that's very consistent with everything you just told me. I'm going to check off do not resuscitate.
Yeah, hey, that's it.
If that happens.
Die once is enough. Huh?
Yeah, I would think so.
Okay.
The second section, Section B, talks about situations that are medically serious situations, but you haven't technically died. You still have a pulse, you're still breathing. But people get into situations with infections. So one example might be if someone had a bad pneumonia. Their breathing may change, their blood pressure may drop, but they're still technically alive. In this section, we would try to figure out what measures that you would want if you were still alive, but getting closer to dying, okay? And there are 3 options here. So there is, and I tell people there's a very aggressive way, there's kind of a middle of the road way, and there's a most conservative way to think about this. So the most aggressive way would be to say that we want full treatment. This would include breathing tubes, mechanical ventilation, electric defibrillation for your heart still, or cardioversion, okay? But I'm not getting the sense that that's what you're talking about.
Oh, I don't want them tubes.
Okay. The second option is limited interventions, which would mean that that you may still elect to come back to the hospital, but you don't want some of the things that we talked about as far as breathing tubes or CPR, but you might elect to have things such as IV fluids or antibiotics or other medications, or even allow them to monitor your heart by a heart monitor. So it would allow you to come back to the hospital for some treatment of things that would be potentially reversible, but we wouldn't do the most aggressive things. Okay. Comfort measures only would be just that. At the nursing facility, if you started a decline in your health, if we thought you had a pneumonia, we would treat you conservatively to manage the symptoms in the comfort of that, but we wouldn't do any of the resuscitation efforts. We would not bring you back to the hospital unless your pain and symptoms could absolutely not be under control there. And that really would just be the type of arrangement where we would allow a natural death to happen if you were declining over time. So given those three options, does that feel something that you feel that you can make a decision on?
The third one you called comfort.
Comfort measures only.
Yeah.
You think that? Okay.
Yeah, I've been in here a couple of times. I don't get better.
Right. They stabilize things temporarily.
Yeah.
Okay. But you're right. Eventually, unfortunately, we have to understand that you may be closer to dying than we hope. But we want to honor what you want for this.
Comfort.
Okay. We'll check that off. The next section talks about antibiotics. So in that same situation, we can choose no antibiotics. So for example, if you had a pneumonia or another infection, we could say we're not going to treat that with antibiotics. We're going to go ahead and do comfort measures and make sure you're comfortable. Or we can do antibiotics for short term and see what happens as a trial. And if it works, then we can continue that or finish it. But if it doesn't work, we could also make a decision to stop that. So that would be a limited short-term option. And then the last option would be is that you would elect to say, yes, I want to use antibiotics with a goal to indefinitely prolong my life as aggressively as they could.
I like that middle one.
The middle one. So
That's what,
a short term of antibiotics to see what
just to
happens.
see. Yeah.
Okay.
Because if it's a little thing, maybe it would be okay.
Yeah, we can try that. And we've already set forth the other things that we know you don't want. Okay. The last situation talks about a situation where we look at artificial hydration and nutrition. That's like the IV fluids that you have, or you haven't had artificial nutrition, but you've ever seen somebody has a feeding tube in their nose or their stomach. Oftentimes we get into situations when people can't swallow. So for example, if you had a stroke and it left you impaired to the point where you couldn't swallow. Okay. There would ultimately be a decision, probably with potentially you or your wife, about what we should do for artificial hydration and feedings. So again, if you couldn't swallow, there are a couple of options. We could say we don't want to do any artificial hydration and nutrition, and just again allow a comfortable natural death as best we can provide. We could provide a short-term trial of artificial hydration and nutrition, again with seeing what's going to happen after potentially a couple of days or a couple of weeks, with the idea that we could revisit that. Or you could say, yes, I would want to have artificial hydration and nutrition with the goal to extend my life in that type of situation. Have you ever thought about that, those kind of issues before?
Yeah.
Okay.
I don't want them tubes.
You don't want to?
Yeah.
Okay.
But I don't know about the water. I mean, I don't want no food or nothing like feeding.
Okay.
I don't know. Okay. I don't want to be thirsty.
Yeah. Well, that's a great question. So what I would say is if a situation happened that either, such as a stroke, that left you unable to swallow, or if a situation happened where you were just very tired and weak, and as a process of dying, you stopped eating and drinking, we can always try to offer you food and water as safe as we can, with the goal of being pleasure and comfort.
Okay.
So if you could still swallow, but you just weren't eating and drinking very much, we would still offer you food and liquids.
Oh, okay.
If you had a problem where you couldn't swallow, we would still be very aggressive to give you hydration for your mouth with swabs and try to make your mouth as moist as we could.
Okay. Let's do that.
Okay, so it sounds like you're electing that we would not do the artificial hydration
Yeah.
and nutrition. Okay,
Yeah.
good enough.
Okay.
All right. There's a couple other, any other things that you can think of beside what I asked you that you would want or would not want to have in terms of medical therapies or anything else that we've talked about?
No, I just don't want none of them tubes.
Okay. And we've captured all that on this one,
Okay.
and that's good. So I'm going to just check a couple of things here that I discussed this with you,
Yeah, you did.
and I'm going to go ahead and sign my name and have you sign your name.
I can do that.
Okay, good. And the other thing that I want to explain about this form is that I'm going to go ahead and make a couple of copies of this.
Okay.
But this form is really intended to go follow you wherever you are. So if you go from this hospital to the long-term care facility, I'm going to have the nurses send this with your chart records. So the nursing home has this.
You gotta mail it to them.
Well, it's going to go with your medical records.
Okay.
And I'm going to give you a couple of copies to keep on your person and give to your wife to have extra copies.
Oh.
And I'd like to, is it okay if I called your wife and explained what we've talked about here today?
Oh, yeah.
Okay.
Yeah.
Okay. So,
She should know.
she should know.
Yeah.
And that's an important thing because if something happens and she wasn't here,
Yeah.
it at least gives me the opportunity to explain what's already
I
happened.
have to have a pink paper with me.
Well, you're not going to keep it on you. It'll be your chart
Okay.
at the nursing facility, and they'll keep it there. And the reason we do this is because we've just had a great conversation, and we want your goals of care to be honored in the way that you want them to be. So this just helps identify to everybody at the nursing facility that if, God forbid something happens to you, you don't want things like resuscitation, and you want to avoid coming back to the hospital, and we would do comfort care there. And in fact, we can also maybe even talk about hospice care once you get to the facility.
Okay.
Okay, so I'm going to make a copy of this, and I'm going to have you sign
Okay.
your name right here,
Okay, want me to sign that now?
Yeah. right there in that box. Very good.
Uh-huh.
Okay. And your full name is Samuel Patch?
And Samuel
E.
Patch.
Samuel Patch.
Yeah.
Okay, Mr.
Oh,
Patch. Okay, yeah, Sam. Well, I'm very glad to meet you today, and I know you shared a lot of very special things with me, and I appreciate that. So we want to do for you as best we can and honor all those things you just talked about. Okay?
Yeah, I'm glad you talked to me.
Well, I'm glad we did too.
Yeah.
And I'll go ahead and give your wife a call if that's okay.
Please.
Okay? You take care, sir.
Thank you.
All right.
Thank
Bye.
Okay.